This is Dr. Thomas Dayspring, Chief Academic Officer at True Health Diagnostics, with a lecture that will discuss evaluating platelet reactivity using the biomarker 11-dehydrothromboxane B2. Platelets, one of which can be seen on the upper right of the diagram, are normally involved in the arterial thrombotic process and play a very active role in the inflammatory aspect of atherogenesis. Platelets produce many molecules, including thromboxanes, which are eicosanoids, meaning 20-carbon fatty acids associated with platelet adhesion, meaning clotting, but also arterial vasoconstriction. And you see the second graphic, which shows activated platelets. There are two types of thromboxane, A2 and B2, and their chemical structure is depicted. They belong to the ether class of organic molecules. Eicosanoids, which are synthesized by all cells except red blood cells, are incredibly potent molecules which are able to cause profound physiologic effects at very, very dilute concentrations. They all function locally at the site of their synthesis through receptor-mediated G-protein link signaling pathways. Eicosanoids collectively encompass the following set of molecules: prostaglandins, thromboxanes, leukotrienes, and lipoxins. The prostaglandins and thromboxanes are collectively grouped and identified as prostanoids. Thromboxane A2 is generated by the enzyme thromboxane synthase from molecules derived from arachidonic acid using cyclooxygenase 1 or cyclooxygenase 2 enzymatic activity. And they are, of course, abbreviated as COX-1 or COX-2 pathways. Thromboxane A2 has a very short half-life in plasma and is very rapidly hydrolyzed to thromboxane B2, which in turn is metabolized in the liver to 11-dehydrothromboxane B2, abbreviated as 11-DHTX-B2, which are then released to the plasma, filtered through the kidney, and are excreted into the urine. So, 11-dehydrothromboxane B2 is a metabolite of thromboxane B2, which is converted from thromboxane A2. Let's go through the pathways that result in platelet activation. In the upper right corner, you see the arachidonic acid molecule, and it, utilizing the enzymes COX-1 or COX-2, is converted to the very potent thromboxane A2. This is able to interact with the thromboxane receptor, which sits on the platelet membranes, and sets off the G-protein signaling, resulting in platelet activation. However, arachidonic acid can simply undergo, via free radical oxidative pathways, conversion into F2 isoprostanes, which you see depicted. Isoprostanes are prostaglandin isomers produced non-enzymatically in vivo from arachidonic acid. They do not use or need the COX enzymes to be produced. F2 isoprostanes can also activate the thromboxane receptor and enhance platelet aggregativity. F2 isoprostanes are a urinary biomarker, and they, as mentioned, are produced from polyunsaturated fatty acids, the vast majority of which are arachidonic acid, by a free radical catalyzed mechanism. They are markers of oxidative stress. And there are several classes of isoprostanes, including F2, which True Health does assay in the urine. And they are very good markers indicative of oxidative stress and lipid peroxidation. And they have been, in studies, shown to be elevated in the earliest stages of plaque formation. Of course, another result of oxidative stress is the formation of minimally oxidized LDL particles, which can also be assayed in the plasma. And sometimes these two biomarkers can go hand in hand. If urinary F2 isoprostanes are up, it is likely that some degree of LDL oxidation is occurring. And of course, that can also be evaluated using the OX-LDL biomarker. Let's review the synthesis of the urinary biomarker 11-dehydrothromboxane B2. At the top of the graphic, you see a platelet cell membrane consisting mostly of phospholipids, on which there are, of course, fatty acids. And after exposure to various lipases, such as phospholipase A2 or C, arachidonic acid is formed. Now, arachidonic acid, a pro-inflammatory fatty acid, can undergo additional catabolism. Let's use the arrows to the right. Using the cyclooxygenase 1 or COX-1 pathways, arachidonic acid will be converted to thromboxane A2. And thromboxane A2, a very active mediator, will induce platelet reactivity, but very quickly it is converted to thromboxane B2. Now go back to the arachidonic acid molecule in the center, and we're going to move to the left. Using the cyclooxygenase 2 or COX-2 pathways, arachidonic acid is also converted to thromboxane A2, which does its cell signaling and then is converted through hydrolysis to thromboxane B2. Thromboxane B2 synthesis occurs in the liver from thromboxane A2, and it is metabolized in the liver to 11-dehydrothromboxane B2, which re-enters the plasma, filters through the kidney, and shows up in the urine where it can be assayed, and you see the molecular structure of urinary 11-dehydrothromboxane B2. So the important take-home from this slide is that arachidonic acid has two enzymatic pathways where it can be converted to thromboxane A2. Too much production of thromboxane A2 results in platelet hyperactivity and other vascular effects. Thromboxane A2 is converted to its metabolite, which is further metabolized, and the metabolite winds up in the urine where we can measure it. So increased urinary 11-dehydrothromboxane B2 is indicative of a state of excess thromboxane A2 activity associated with platelet hyperreactivity, which is certainly a cardiovascular risk factor. This is how urinary 11-dehydrothromboxane B2, which is also called the AspirinWorks test, shows up on the True Health Report form. On the mid-right of the diagram is how one would order it, using a simple checkoff of the biomarker. And as mentioned, this is going to be a clinically useful in vivo indicator of platelet activity, and is used to evaluate the COX-1 and COX-2 pathways of thromboxane biosynthesis. And this biomarker may be used to assess an individual's platelet activity and associated risks for developing cardiovascular events, as well as potentially identifying patients who are likely to benefit from low-dose aspirin therapy. So it's important to realize that by itself, it is another tool to evaluate cardiovascular risk. And there is a range where if it's above 1,500 picograms per milligram, it is considered abnormal, and below that, it is considered normal. This slide evaluates mortality rates based on urinary dehydrothromboxane B2 levels. And you can see there are tertiles. On the left are rather low, normal levels. In the middle is the gray zone between 1,000 and 1,900. And on the right are significantly elevated concentrations of the biomarker. And the y-axis, of course, is mortality. And in patients who are taking aspirin, it is a poor prognostic sign if the AspirinWorks test remains elevated. This is another graphic using Kaplan-Meier survival estimates showing the on-aspirin mortality rates as they correlate with the urinary 11-dehydrothromboxane B2. And you can see the higher levels, the increased slope of the line, which is indicative of increased mortality over time. So if you're on aspirin, it is a rather undesirable additional risk factor if the AspirinWorks test stays abnormal. I now want to discuss the effect of aspirin therapy on urinary 11-dehydrothromboxane B2 and platelet reactivity. So you're familiar with what you see here, the COX-1 pathway where arachidonic acid is converted into thromboxane A2. Now at rather low doses, baby aspirin incredibly effectively blocks the COX-1 pathway, which would diminish the production of thromboxane A2, diminish platelet reactivity, and of course cause reduced urinary levels of urinary 11-dehydrothromboxane B2. So if you had a patient where the biomarker was elevated and you prescribe low-dose aspirin, it would not be surprising to see a decrease in the level in the urine, which certainly would be an indication that aspirin has inactivated the COX-1 pathway. However, you remember there is more to the story here. Arachidonic acid via the COX-2 pathway can also generate thromboxane A2 and generate ultimately the production and excretion of 11-dehydrothromboxane B2. Unfortunately, aspirin has very little effect on the COX-2 pathway. So it is possible to prescribe aspirin to a patient with elevated urinary thromboxane B2 and nothing happens. Aspirin virtually always takes out the COX-1 pathway at low dose, but it may do nothing to the COX-2 pathway. So the test remains abnormal, but that does not mean that aspirin is not working. Aspirin has indeed taken out the COX-1 pathway, which is desirable, but there are other issues at play activating the COX-2 pathway. And that pathway is associated with many other types of inflammation, such as related to insulin resistance, autoimmune diseases, infectious diseases. So in an instance where a patient is on aspirin and still has elevations of urinary 11-dehydrothromboxane B2, one has to be suspicious that additional inflammation that is activating the COX-2 pathway is at play, and they should be searched for, identified, and treated if at all possible. Aspirin preferentially inhibits the platelet COX-1 pathway 50 to 100 times more effectively than the non-platelet COX-2 pathway, and it does that at the very tiny baby doses. You don't need 325 milligrams in the overwhelming majority of patients to inhibit the COX-1 pathway. Even low doses are all that is necessary to reduce thromboxane A2 production. Now, urinary 11-dehydrothromboxane B2 is an FDA-cleared assay, and clearly it is a biomarker that looks at the metabolite of thromboxane A2, which reflects thromboxane A2 activity on platelet hyperreactivity. Urinary 11-dehydrothromboxane B2 cannot discern platelet-specific COX-1 production of thromboxane A2 or B2 versus global production. So if this biomarker is elevated, more than likely it's coming from reactive platelets, but under other conditions, other cells can produce or activate that enzymatic pathway. Now let's discuss the alternate pathway of platelet activation. You're familiar with what you see here. Arachidonic acid, if it's overproduced, goes through the enzymatically COX-1 or COX-2 pathways, produces increased amounts of thromboxane A2, which activates platelets and creates a hyperthrombotic state. Thromboxane A2 is metabolized in the liver, and the metabolite of thromboxane B2 shows up in the urine, and we can all measure that. But there's that other pathway we had briefly discussed. Using non-enzymatic pathways that will result in platelet hyperactivity. Arachidonic acid via oxidative pathways and free radicals is converted to a series of molecules called F2 isoprostanes, which are also capable of activating platelets and causing a prothrombotic state. And of course, that has nothing to do with the enzymatic pathways of increase in thromboxane A2 production. So in a patient on aspirin where the urinary 11-dehydrothromboxane B2 test remains abnormal, you have to realize you have inhibited the COX-1 pathway, that is desirable, but the abnormal urinary biomarker could be a result of COX-2 activity, and you should search for causes of that inflammation, or it may be due to oxidative stress generating F2 isoprostanes. And of course, that can be assayed in the urine also, and it can be treated by aggressive, wholesome nutrition. This slide looks at patients taking aspirin who, based on the results of the AspirinWorks test, 11-dehydrothromboxane B2, are classified as responders, R in the diagram, or non-responders, NR in the diagram on the x-axis. And you notice that the non-responders typically might also have an elevated high-sensitivity C-reactive protein or elevated F2 isoprostanes, which would suggest that even though the COX-1 pathway is inhibited, the COX-2 pathway or the oxidative pathways are at play in such patients. This slide demonstrates that in patients taking aspirin, urinary 11-dehydrothromboxane B2 results correlate with the F2 isoprostanes. You see 3 bars. In the middle is the normal AspirinWorks patients. In the middle would be the gray zone, and on the right would be very elevated levels. And you can see the AspirinWorks is more commonly going to be elevated in circumstances where urinary isoprostanes are also elevated. So these two tests often can go hand in hand, or can help you understand that this biomarker in the urine can still be abnormal, not because COX-1 has not been inhibited, it almost always is with low-dose aspirin, but oxidative inflammation is also going on. Thus, when using AspirinWorks, or urinary 11-dehydrothromboxane B2 as a follow-up test, keep in mind that the inflammatory COX-2 thromboxane A2 and the oxidative stress pathways maintain platelet hyperactivity irrespective of aspirin inhibition of the COX-1 thromboxane A2 pathway. You do not stop the aspirin. You want to take out the COX-1 pathway, but you have to reevaluate what might be setting off the COX-2 or the oxidative pathways. Interestingly, this phenomenon appears to be more significant in women. Thromboxane-poor aspirin response identifies patients with enhanced inflammation and oxidative stress that require anti-atherogenic therapeutic programs beyond aspirin inhibition of the COX-1 pathway. And what that additional therapy is depends on what else is going on. If it's an autoimmune inflammatory disease, you might address that. If it's inflammation associated with diabetes or insulin resistance, that could be addressed. If it's oxidative stress, that can be addressed through nutrition and other therapies. Here are the factors that influence the response to aspirin. In the left-hand column, well, if a patient is not compliant, it's certainly not going to work. There is aspirin intolerance in some people, which could limit the patient using it. Drug-drug interactions are at play if they're on NSAIDs or other antiplatelet or anticoagulant medications. Absorption of aspirin can be variable depending on what product a patient ingests. Is it enteric coated or not? Of course, in an acute coronary syndrome, there is significant overproduction of thromboxane A2, and it would be tougher to inhibit in that situation. There are studies showing marked hypercholesterolemia can also aggravate or hinder the effect of aspirin on thromboxane A2, as well as abnormal glycemic issues. The middle column discusses some of the cellular factors that go on that influence the response to aspirin, and on the right are some of the genetic factors that could be at play affecting platelet reactivity. Here's a simple algorithm. If a patient has the AspirinWorks test, meaning measurement of 11-dehydrothromboxane B2 in the urine, it might come out in the optimal range. Now, if that person is not on aspirin, I'm not so sure what administration of aspirin would do, because the COX-1 pathway or the COX-2 pathway does not seem to be at play. Now, if this patient is already on aspirin and it's optimal, you certainly know the aspirin use has inhibited COX-1. Should you stop it or see what happens? That would depend on the underlying risk of the patient. In very high-risk patients, unless there's a contraindication, most would continue the aspirin. But what would happen if it comes back in the high-risk range? Now, if that patient is aspirin naive, this, barring any contraindications, would be an indication to consider low-dose aspirin therapy. If the patient, however, is already on aspirin and it comes back abnormal, increasing the aspirin dose is unlikely to have much more efficacy, because the abnormality is likely due to COX-2 and/or oxidative stress. So, in circumstances where the biomarker is abnormal, review patient compliance, check for absorptive issues with the aspirin, make sure lipids are very aggressively treated, and that there are no drug-drug interactions that might be on board, such as concomitant use of NSAIDs. Then you have to evaluate, COX-1 is probably taken out if you're on aspirin, what might be causing the COX-2 pathway or the oxidative pathways. And then, if identified, they would have to be addressed. Under all of these circumstances, one can ultimately retest the urinary thromboxane B2, especially if you've tried to address the other issues. But remember, even if it persists and you have aspirin on board, the COX-1 pathway is almost certainly inhibited. So chasing aspirin any further is unlikely to result in additional efficacy. So continue the aspirin. You understand the COX-1 pathway has been taken out, and then evaluate the other pathways and see what you can do about it. Thank you so much for listening.